So hello and welcome to this Paediatrics podcast on the clinical presentation of a child with a cough. During this podcast I shall consider the mechanism and pathophysiology of a cough, the important groups of causes and which aid groups they're particularly associated with. Then in the second half of the podcast I shall go into details about the assessment of a child with a cough, including the standard history, examination and investigations that may or may not be needed. So let's start with the question, what is a cough? This is all fairly basic. Cough, or sometimes known as tussis, is defined as a rapid expulsion of air from the lungs. A cough is in essence a physiological mechanism that exists to clear the airways of fluid, mucus or other materials. However, when the cough becomes persistent and distressing to the patient, or child in this case, we term it as pathological. It is important to understand the mechanism of cough. A cough is triggered by stimulation of two types of sensitive fibres that are found throughout the respiratory tract. These are the rapidly adapting irritant receptors, or RARs, and the C fibres. These may also be found inside the external auditory canal and tympanic membrane, and this is why irritating the inside of the ear canal with a Q-tip can cause a cough reflex. These cough receptors can be stimulated either by chemical or mechanical means. The reflex from this stimulation relays via the brainstem before affecting a cough. The cough is actually affected by the contraction of the diaphragm and respiratory muscles against a closed epiglottis, increasing the pressure inside the thorax. The epiglottis is then opened suddenly, releasing a short, sharp burst of air, which is what we know as the cough. So, we've considered the definition and mechanisms of cough. Let's now discuss the various causes of a cough, and importantly, how to break them down. With paediatrics, it is useful to keep in mind the age groups to which each cause is particularly relevant, as this can easily cut down your list of differentials in an exam scenario. Overall, we may divide the causes of a cough up into infective, allergic, aspiration, environmental, psychogenic, and we give a special group to cystic fibrosis. We may of course break these down even further. Under infective, we have very commonly a viral cough. We may also see pneumonia and TB. We may see bronchiolitis, particularly in infants aged between 1 and 9 months. Viral croup is another thing that we see, commonly in children between 6 months and 6 years. And then of course there's always whooping cough, or pertussis. Under allergic causes, once again, we have very commonly the postnasal drip that occurs due to allergic rhinitis. And we may also see asthma, particularly in children aged more than 2 years. Under aspiration, we see gastroesophageal reflux disease, that's particularly prevalent in infants, and occasionally cough in this group can be due to an inhaled foreign body. Environmental irritants include smoking, either passive smoking in young children or active smoking in teenagers, and occasionally inhalation of other irritant substances. We may also see psychogenic coughing in the context of habit cough, and finally cystic fibrosis, which we'll talk about a bit later. So let's now move on to talk about the assessment of a child with a cough. As always, we may divide the assessment into two basic bits. Firstly, the emergency assessment, that's not often needed but very important to remember. Then of course a more detailed assessment, including the history, examination and investigations. In exams, it's particularly important to always mention the initial emergency assessment and resuscitation with respect to the airway, breathing and circulation. Taking a paediatric history follows along the same lines as an adult history, but there are a few extra aspects which you need to remember. Firstly, age. Age is crucially important to check from the outset, as this will affect the list of differentials you might be considering. Next, we move on to the presenting complaint and history of presenting complaint. In paediatrics, this is often taken from the parents. Next, we come to the past medical history, drug history and allergies, which is the same as in an adult history. Then we move on to the family history. In paediatrics, it's always useful to draw a family tree, as genetic patterns can be seen more easily in this way. We come then to the social history. This is highly crucial in paediatrics, as the child's family life, home environment and social environment can have a major effect on the child's health. Don't forget to ask about smoking, including members of the household that smoke, and also alcohol and drugs with older children. The last three elements are particularly important in paediatrics and include the birth history, which, depending on the child's age, you'll need to know about pregnancy, how the child was delivered, and if there are any complications either before or after the birth. In the developmental history, you want to know whether the child reached their developmental milestones at the expected age, or for an older child, how he or she is getting on with schooling. Under the vaccination history, if they're under 5, always remember to see the red book. If older, ask about all the childhood vaccinations and whether they had them. It's really worth memorising the current vaccination schedule, as this often comes up in exams. Let's now talk a little bit about some specific aspects of the history that you need to ask. You should ask some more details about the cough, and to do this, keep the Socrates mnemonic in your mind. Now, although this mnemonic Socrates is specifically designed for the symptom of pain, it can actually be useful for any symptom. So, first of all, when did the cough start? If the cough was of a very sudden onset, you might want to think about inhaled foreign bodies and inhalation of irritant substances. If the cough was of a more acute onset, but not entirely very sudden, then it could be any of the infectious causes. If there's a long history of cough, you want to think about things such as gastroesophageal reflux in kids, postnasal drip, asthma, habit cough, and then finally some rarer things such as TB, RSV, mycoplasma, Bordetella pertussis infection. Next, you want to ask exactly how often does the child get the cough and when. If the cough particularly occurs in the early morning or at night, then think about asthma. In infants who cough after feeds, always think about gastroesophageal reflux. Next, ask what the cough sounds like. If there is a barking cough in a young child, think about croup. On the other hand, if there's a spasmodic cough that occurs often after the child has taken a deep breath in, think of pertussis. Next, you want to know, is there anything that exacerbates or relieves the cough? Here, parents may report that exposure to cold increases the frequency of the cough, and for this you want to think about asthma. Next, we want to know, does the child have any associated symptoms such as high fever, wheeze, runny nose, or failure to thrive, or general concern from the parents? If there is a high fever, you want to consider severe things such as pneumonia, croup, or pseudomembranous croup. If there is wheeze, think about asthma, bronchiolitis, and gastroesophageal reflux in infants. In the presence of a runny nose, obviously you want to think about allergic rhinitis. Failure to thrive, often with abnormal stools in association with cough, is an indication to start thinking about cystic fibrosis. Is the cough productive of sputum is the next question. If so, what does it look like? Sputum that is green, brown, or dark yellow is suggestive of a bacterial cause, particularly bacterial pneumonia. In addition, hemoptysis, or blood in the sputum, is suggestive of TB. For the rest of the history, try to consider the following. Is there a history of a similar problem? For example, recurrent chest infections bring cystic fibrosis to mind. Does anyone else in the family have a similar problem? This suggests that perhaps the cause could be genetic or an infectious contact within the household. What is the home environment like? If the home environment is crowded or dirty, this makes an infectious cause seem more likely. If there is associated delay in developmental milestones, you might want to think about cystic fibrosis and other chronic conditions. Also, you might consider, have any other children at school or nursery been unwell? Finally, don't forget to ask about vaccinations. If the child missed their DTP vaccination, pertussis becomes a much more realistic diagnosis. So, let's move on to the examination. When examining a child, remember to take advantage of any opportunity. Many paediatricians will go straight into listening to the chest while a young child is still asleep or feeding. Throat examination, on the other hand, is usually left to the last, as it may distress the child. Use your own system for examining the child, but for a child with a cough, remember to cover the following important areas. Firstly, assess the child for systemic features. So that means you want to look at generally how they are, you want to look at their pulse, their respiratory rate, whether there's any associated dry mucous membranes, drowsiness. All of these things point to severe systemic upset with the cough. You also might want to look for rashes. Next, you want to look at the respiratory system. Here, once again, look at the respiratory rate, check for unequal expansion, auscultate for areas of consolidation, and look for extra sounds such as wheeze. Finally, remember to look in the ear, nose, and throat for evidence of infection or inflammation. By now, you should have a short list of possible differentials, or you might even have decided on the probable diagnosis. We use this basic modality framework to decide what investigations to do. However, remember that most of the time these investigations are not necessary, particularly in the primary care setting. So first we have cultures. This might include blood cultures if the child is febrile and septic, as well as urine dipstick and analysis. For bloods, think about capillary blood gas. Remember that ABGs are very rarely done in children. And venous bloods, particularly the full blood count, looking for anemia and a raised white cell count. Use an EASE to assess for dehydration. And CRP and ESR to look for inflammatory markers. Serological tests for antibodies to specific organisms are not often necessary. Under imaging, you may want to perform a simple chest X-ray to look for evidence of pneumonia, TB, or rarely an inhaled foreign body. Scopic stroke biopsy, this isn't really relevant here, but for completeness, bronchoscopy may be used as a last resort for finding an inhaled foreign body. Under functional or specific, we include, importantly, the peak expiratory flow rate for asthma, and then secondarily a sweat test for cystic fibrosis. We're not going to talk in detail in this podcast about the management of cough, as this will be covered in other podcasts according to the specific diagnosis. So, let's go through a few take-home points. Cough is very common. One of the most important things to remember about cough is that it can be divided up into a number of sets of causes, including infective causes, allergic, causes due to aspiration, environmental irritants, or very occasionally psychogenic cough. It's important to keep in your mind these lists of differentials as you're going through the history and examination. Also, remember all the extra stuff that you need to ask for the paediatric history, such as the social history, birth history, developmental history, and vaccination history. So that's it for this podcast. Many thanks for listening. Also, a big thank you for Chiara Taylor for her hard work in preparing this podcast. I'll see you again soon with more Paediatrics podcasts.